Prader-Willi syndrome and Angelman syndrome are two genetic disorders involving chromosome 15 and are known as imprinting syndromes. Genomic imprinting is the process by which only one copy of a gene in an individual, either from their mother or their father, is expressed while the other copy is suppressed. So genomic imprinting is yet another mechanism by which genetic disorders are manifested. The region close to the centromere of chromosome 15 is the region that is involved in both these disorders, and this is a region that is imprinted. The genes that are shown in blue are only expressed in paternally inherited chromosome 15, and the genes shown in red are only expressed in the genes that are inherited from the maternal chromosome, from the maternal side of the family. So this is why it is known as imprinting syndrome. So depending on whether the whether the chromosome 15 region is inherited or not inherited from the father or the mother, the syndrome that would result would be either Prader-Willi syndrome or Angelman syndrome. Prader-Willi syndrome occurs in about 1 in 15,000 individuals. The cardinal features include severe infantile hypotonia, hyperphagia with the onset of obesity during early childhood if the consumption of food is not controlled, developmental delay with learning and behavioral problems, short stature with small hands and feet, hypogonadism, hypogenitalism due to growth hormone and other endocrine deficiencies, mild craniofacial dysmorphism, and some psychiatric phenotypes that could include features of autism. The errors in genomic imprinting in Prader-Willi syndrome are more than one. The de novo deletion of paternally inherited chromosome 15 region is the reason for Prader-Willi syndrome in about 60% of the cases. So because of this deletion, the paternally derived genes are not expressed, and that is the cause, the genetic cause for the Prader-Willi syndrome. In about 35% of the cases, both chromosome 15s will appear normal. However, both of them are inherited from the mother, so that is maternal disomy. And because there is no paternally derived chromosome 15, the genes on that chromosome 15 are not expressed. There is also a region on chromosome 15 known as the imprinting center, which is responsible for the imprinting process. If there are microdeletions or mutations of this region, that can also result in Prader-Willi syndrome. And there are other chromosome 15 abnormalities that can result in the syndrome. So shown here are the various reasons, various mechanisms by which genomic imprinting is affected. In a phenotypically normal individual, you can see on the left how chromosome 15, there is one that is inherited from the father and one from the mother. In the next figure, you can see that there is a deletion of the paternally inherited chromosome 15. And in the next one, you can see how both the chromosome 15s are inherited from the mother, so that is maternal disomy. And in the next figure, you can see how this could be due to an imprinting defect, whereby the neither of the chromosome 15 have the genes required for normal development being expressed. There are different types, genetic subtypes, even in the group of deletions. They are mostly de novo, and they consist of different sizes of the deletion, and they are classified as type 1 and type 2. Type 1 deletion is larger and type 2 is smaller. So most of them fall within this category of type 1 and type 2, but in about 5% of the Prader-Willi syndrome individuals, the deletion does not fall in either one of these categories. So shown on this slide is the extent of deletion, the class 1 and class 2. The class 1 deletion has a larger size deletion compared to the class 2. To confirm a diagnosis of Prader-Willi syndrome requires molecular genetic testing for the identification of the Prader-Willi genetic subtype. That is, you want to know whether it is a deletion, whether it is a maternal disomy, or whether it is imprinting defect. SNP array can characterize the extent of deletion as well as whether it is uniparental disomy, because you will see loss of heterozygosity in that region. In the maternal disomy chromosome of chromosome 15 in Prader-Willi syndrome, again, it depends on whether there are subtypes. It depends on whether the non-disjunction occurred in meiosis 1 or meiosis 2. And the older mothers have a greater chance of having a child with Prader-Willi syndrome due to maternal disomy compared to those having the typical deletion-associated Prader-Willi syndrome. There are familial cases of imprinting center defect where the father contributes a microdeletion of the imprinting center received from his mother. But this is uncommon, however, it can happen. So if the imprinting center defect is inherited from the mother, it does not affect the male child. However, when this male individual, that is the father, transmits that particular microdeletion or mutation to the next generation, there is a 50% chance that the child would be affected. So this is why it's important to know what is the mechanism, the genetic mechanism that is involved in the syndrome in a given family. Shown here is a family history, a pedigree of a family in which the imprinting center defect is transmitted from the carrier female to individuals in the family who are not affected. But when a carrier male transmits that particular allele, there's a 50% chance that their children would have Prader-Willi syndrome. So in this case, on generation 3, individual 3 is a female carrier, and because it's a female carrier, there is no risk of having a child with Prader-Willi syndrome. However, on that particular generation, you have individual 13 who is a male and is a carrier of the imprinting center defect, and that individual is at a 50% chance of having offsprings with every pregnancy, of having a child with Prader-Willi syndrome. In different age groups, one can use different phenotypic features that would prompt one to do DNA testing for Prader-Willi syndrome. At birth, it's usually just hypotonia, but as the child grows, the other features will be manifested. In the 6 to 12 age group, for instance, excessive eating with central obesity is an issue if it's that needs to be controlled. There is always the global developmental delay and short stature, etc. So these are the features that one can use that could prompt DNA testing for Prader-Willi syndrome. Management is multidisciplinary to deal with many phenotypic features. In older children, rigorous control of diet and securing the food environment is important to prevent complications which can result in which represent the major causes of morbidity and mortality in Prader-Willi syndrome. Angelman syndrome, the prevalence is about 1 in 12,000 to 20,000. It's characterized by microcephaly, severe intellectual defect, speech impairment, and many brain-related abnormalities. One of the most frequent and common features is frequent laughter. Patients with Angelman syndrome are constantly laughing, so this is a very common feature, and it could be an indicator that the patient has Angelman syndrome. The genetic mechanism in Angelman syndrome is the result of loss of function of a particular imprinted gene, which is the UBE3A, which is located at the proximal region of the chromosome 15. So this loss of function can be due to a mutation on the maternal allele, could be due to a deletion of the maternally inherited chromosome 15 region. It could be due to paternal uniparental disomy of chromosome 15, or it could be due to an imprinting defect in that region. The chromosomal deletion tends to cause the most severe symptoms, and this could be because of co-deletion of other genes in that particular region. Shown here on the left are the various classes of deletions that are seen in Angelman syndrome. And on the right again, you can see how in a normal individual you have a paternally and maternally inherited chromosome 15. In the next panel, you can see how there is a maternally inherited chromosome 15 that shows deletion of the region close to the centromere, and that is the reason for the Angelman syndrome in that particular group of patients. Or you can have both chromosome 15s that are structurally normal, however they are both inherited from the father, so that would be due to a paternal uniparental disomy. You can have an imprinting defect in the maternally inherited chromosome 15, so that could result in Angelman syndrome. And you can also have a mutation of the UBE3A that could manifest in Angelman. So in a family, if you have a defect of the imprinting center associated with Angelman syndrome, if it's transmitted from the father, the individuals are normal, although they carry the defect, but they are at a 50% risk of having children with Angelman syndrome, because now it becomes a maternally inherited chromosome 15 with the imprinting center defect. So one can encounter a family like that. DNA-based methylation testing will detect more than 99% of individuals with Prader-Willi syndrome and approximately 80% of individuals with Angelman syndrome. There are alternative testings available, like fluorescence in situ hybridization to detect deletions of that region, or you can, in the case of Angelman syndrome, if in about 10% of the individuals it's due to a UBE3A mutation, and this will require sequencing analysis of the gene. So this is to just show you how the inheritance pattern is different in Prader-Willi syndrome and Angelman syndrome. Although they both involve the same chromosomal region, because of the imprinting mechanism, how In one, it is paternally inherited chromosome that is imprinted, and in the other, it's a maternally inherited genes that are imprinted. So there is a difference in how the inheritance pattern will look. The frequency and disomy, the uniparental disomy, frequency of the deletions and the uniparental disomy and the imprinting defects are shown in this. So based on that, the inheritance, the recurrence risk will also change. There are other genes that are involved, the other regions of the genome that are involved in imprinting. They are on chromosome 6, 8, 11, 14, and 20. So imprinting is yet another mechanism by which genetic disorders arise. So to recap, genetic and molecular characterization is essential for confirming a diagnosis of Prader-Willi syndrome and Angelman syndrome. It is also required for appropriate management, including providing prognostic information. It is very important for determining recurrence risk because it differs with the mechanism, and so that is involved, that is required for genetic counseling. You can use SNP array, can be the initial assay to detect deletion and uniparental disomy, but sequencing may be essential to detect imprinting center mutations. If you would like to discuss this further and if you have questions about this, please feel free to email me at mtgenetics@gmail.com.